Welcome back to the San Antonio Ophthalmology course review. This is Daryl Baskin. We're going to talk now about age-related macular degeneration and other causes of choroidal neovascularization. This is my family back in Burundi. A lot of pictures from that lovely country and in front of the house that we lived in at that time. We had a lot of fun in Burundi. One of the fun things we had was water from leaky roofs hitting our head when we were operating. This is Adrian, doctor that we worked with there. But this is the retina room as well. We actually had a scope donated by Wills. Ceiling mounted, which is actually pretty inconvenient. We had to build something to hold it up. At any rate, there's another picture that I can't find with the same lady holding up a fly swatter in the other hand. So, because we also had a fly problem. And we had a rat problem. These are some rat traps I got while I lived in France because I'd heard about the issues. And so sure enough, we caught that sucker. That's my buddy John Cropsey. Tell him, don't you come back now. All right. So AMD genetics, we think genetic factors account for at least 55% of the total variability in AMD risk. I suspect it's actually higher than that. I have proposed the name to my residents of hereditary age-related maculopathy, HARM. Hasn't really taken hold yet. I also said boomer maculopathy. Thought everybody would like that. So we'll see. There's at least 34 genetic loci. Some papers are showing over 52 now that are considered risk factors. Complement systems often implicated. If you want to read more about it, there's a reference. I think the main two you need to know for testing purposes are the CFH and the ARMS2, and I don't really think you need to know specifically what the greater risks are. Just know that if you've got homozygous DCVs in both genes, you got a 50-fold higher risk than the average person in the population. The defining lesion of dry AMD is the drusen or the drusen, and it may be accompanied by RPE hyperpigmentation or RPE atrophy. They talk about this in the book a lot, and I find it to not be that interesting, but basal laminar deposits, basal linear deposits. Drusen do affect the overlying photoreceptors and can cause, and this is important to know for your patient care, mild to moderate vision loss, decreased contrast sensitivity, decreased color vision, impairment of dark adaptation. If you spend time talking to your AMD patients long enough, you're going to hear about the dark adaptation quite a bit, especially for my patients who are farmers. You'll hear about the other things as well, especially in the painters. So dry AMD, we talked about focal hyperpigmentation atrophy. GA is defined as greater than 175 microns or more in diameter, often spares the fovea until latent disease. The rate of progression is here. That's not a really great number. I wouldn't memorize that. It's actually, we think it's the GA growth is strongly related to lesion perimeter. I hope that the BCSC incorporates this article in the future. Great insight. And here we see some typical pictures of GA. Okay, this is what it looks like on OCT, autofluorescence, and it looks like that's an IDEN photo. And then you can see hypertransmission defect, a different kind. This is OCT hyperreflectivity beneath the RPE in the areas of GA. And we have seen these before. Now we're going to see them on OCT. These are these little guys. We call them witches' hats. Subretinal drusenoid deposits, otherwise known as reticular pseudodrusen. I don't like the word pseudo anymore, so I don't want to use it. RPDs, SDDs are smaller than soft drusen, are located in the apical surface of the RPE. Again, the witch's hat, typically more heavily distributed in the superior macula. Unfortunately, they're higher. They are associated with a higher risk of atrophy of the photoreceptors, GA, and possibly CNV. That kind of goes back and forth depending on the study you read. I, at this point, don't tell my patients when they have these because it's just bad news and they've got enough bad news in their lives. We don't have anything to do about it. You've got a differential diagnosis for AMD. Believe it or not, macular hole used to be on this list. I don't think it is anymore. That was in the pre-OCT days. Central serous chorioretinopathy. Pattern dystrophy is a big one. Adult onset foveomacular vitelliform dystrophy. Drug toxicities. Pentosan polysulfate sodium is not in the book yet, but it will be. That's a really big one that's come about in the last few years, Elmiron or Elmiron. So if vision loss is present, I refer to low vision. This might be the most important thing I do. Amsler grid vigilance, return precautions, lifestyle modifications, micronutrients. Those lifestyle modifications include smoking cessation, obesity reduction, blood pressure control. I also recommend a Mediterranean diet and exercise. Those are not in the book, but they will be someday, because we've got really good, robust data to suggest that, and keep on taking your AREDs too, even to get GA. We now know, I've been saying that for years, now we have proof. AREDs looked at vitamin C, E, beta carotene, because why not, and zinc oxide with cupric oxide to prevent zinc-induced anemia. So I think the key point here is there's a 25% reduction of risk to progression, risk for progression to advanced AMD at 5 years for people that were taking AREDs, the original ones. And then later on we said, okay, hey, people are taking beta carotene are higher risk if they were smokers for getting lung cancer. So let's see if lutein zeaxanthine will work just as good, and they do. Omega-3 was not found to be helpful, sad, and zinc was reanalyzed, and 25 is almost as good as 80, so we stuck with 80. There's a lot of disproven therapies for dry AMD, macular laser photocoagulation, rheophoresis, lamipolizumab. There's more. And the FDA, I'll come to that in a moment. And there's this, it's important for you to tell patients the bad news, okay? So if you have dry AMD and you're not misdiagnosing it, they will eventually get geographic atrophy and they will eventually get blind if they live long enough. I tell patients all the time, if you live to be 150, you will be legally blind, sort of a miracle drug. So I just think of it as you're on this highway, this is where you're driving, you have some levers that can slow things down, as we mentioned before, AREDS 2, exercise with the dose-response curve, and Mediterranean diet. So GA, there are FDA-approved treatments. I do not recommend initiating them. We could talk about that offline. I have a lot to say about this. The European Medicine Agency agrees with me, by the way, and they have rejected every request to get approval for these terrible drugs in their country, on their continent. And just like Tom Hanks on Black Jeopardy said, I got a lot to say about this, and I do, and we don't have time for it. It's also not BCSC approved at this point. So I explain to patients detours can happen on your way to geographic atrophy. You can get wet AMD. It's an addition to the disease. It's not a replacement of. So once you have wet, it's not like you don't still have dry. You still have dry. Again, I'd like to call this harm with plus disease. We'll see. So wet AMD overview. Presence of macular neovascularization, previously called CNV, defining characteristic. Patients are going to be symptomatic. So if you ask a patient about, a change in vision and they don't have one, then probably that little bit of subretinal fluid you're seeing under their fovea is a vitelliform lesion of some sort, or SHRM. You think it's SHRM, but it's actually just a vitelliform lesion. So check for symptoms. Patients will notice. I have seen a few that haven't, but like 90+% have. So subretinal fluid, exudate, blood, pigment ring, PED, RPE tear, C-fan pattern of subretinal vessels. Wow, that doesn't give it away. So this is just with an OCT, just some key findings. This is the pigment epithelial detachment, subretinal fluid. Anybody know what this is? That's the MNV. That's a type 1 CNV. This is the SHRM. Here we go. Oh, I already said type 1. Here we go. Starts underneath the RPE is type 1, just barely on top of the RPE is type 2, and type 3 is what we used to call RAP. Basically, arises from the deep capillary plexus of the retinal vasculature. That's why we don't call them all CNVs anymore, because one of them isn't C. What do we see here? We see that grayish-green membrane, and then here we see an early FA, kind of bright, lacy, well-defined lesion. Now it's no longer well-defined. It's still bright. It's got leakage. It's a type 2 MNV, classic CNV. We just showed you that one. Occult CNVs is fibrovascular PED, irregular elevation of the RPE. They get this kind of stippled leakage or late leakage. And then the type 3 MNVs are a little bit harder to diagnose. They produce a focal hotspot with late CME or pulls that they pull into a PED. So here's a 77-year-old male, 20/70 vision. We see this kind of stippled hyperfluorescence later on. I'm going to call that a type 1. That's an occult CNV or MNV. These lesions are little PEDs. And then here, this sign is related to this kind of multi-layered appearance, sub-RPE cholesterol, crystal precipitation. This is a chronic fibrovascular PED. We call this the onion sign. This is in the book. This sign's kind of hard to know what I'm thinking, but essentially we're seeing Brooks membrane. It's distinctly visible, whereas typically it's not in normal OCTs, normal eyes. This is called the double layer sign. You will see this alluded to a lot because it has prognostic significance. 1 year risk of CNV is 21%, and if you have it, 4% if you don't. CNV and OCTA, sometimes can be hard to see. I tend to scroll through. I create my own custom slabs and move it around a lot. But there's the CNV. We treated it. 30 days later, you can still see a little bit of abnormality there, but it's mostly gone. PCV is a key one. Multiple recurrent serous RPE detachments. It's basically a variant of type 1 MNV. Originally, we saw, and sometimes the question stems will still have African American or Asian ancestry with high blood pressure, but we see it all. We see it in other demographics for sure, but that's still, there's preponderance in that group. 20 to 50% of all wet AMD cases in Asians probably PCV based. Caucasians is less than 5%. Okay, multifocal nodular orange. You get vitreous hemorrhage a lot more commonly with PCV than regular AMD. We had a patient with this terrible case, actually, hemorrhagic RD vitreous hemorrhage due to PCV just a few months ago at UT. I think he ended up having his eye removed. Thickened choroid, often present. Basically, this one study showed that PDT was with or without our ranibizumab was superior to ranibizumab, but then this other study came out and said aflibercept monotherapy was non-inferior to aflibercept with PDT. So we don't really do PDT for it that often. Some people do, though. Subretinal fluid, nodular orange lesion, a lot more easily seen on FA and ICGA. These are the polyps. Laser photocoagulation can be used for CNV lesions that are far away from the foveal center. PDT was introduced in 2000. Not used commonly for wet AMD. And then anti-angiogenic therapies are the mainstay. So what are the four main effects of VEGF? Because we talk about anti-VEGF inhibitors all the time. So we know about angiogenesis. So VEGF promotes abnormal new blood vessels. Or we'll just say new blood vessels. It promotes permeability. The original name of VEGF was VPF, vascular permeability factor, named by somebody named Sanger, David Sanger, somebody. It prevents apoptosis in endothelial cells, and then it promotes lymphangiogenesis. So that together is SLAP, S-L-A-P, the VEGF SLAP. I don't find this mnemonic to be helpful, but there it is. Here's a list of some inhibitors that we have for VEGF right now. Pegaptinib nobody uses. Bevacizumab, ranibizumab, aflibercept. Brolucizumab almost nobody uses due to side effect issues. Faricimab, aflibercept 8 milligrams. That's Eylea HD. We have ranibizumab biosimilars. Now we have aflibercept biosimilars, or at least one, Pavblu. And then there's some trials I'm listing here. I'm really only going to hit some highlights on the next slide. Important lessons that we learned. Excite and Peer, those are ranibizumab studies. Quarterly treatment is not good enough. Horizon with ranibizumab. Most visual acuity gains made in Anchor and Marina were lost. This Horizon was an extension study with PRN. Were lost after patients went PRN. But this is in the old days when we didn't really know the best treatment algorithms. CAT study, that was ranibizumab versus bevacizumab, and 5-year data showed about 50% maintain at least 20/40 or better reading, or 20/40 or better vision. That's reading vision, and patients will want to know, what am I going to lose on my vision? I quote this data a lot. GA development or increase may be stimulated by VEGF inhibitors. That just makes me sad. Radical and Denali basically showed that some PDT plus ranibizumab combo therapies reduce treatment burden, but visual acuity outcomes are inferior to VEGF-I monotherapy. That's VEGF inhibitor monotherapy. Let's talk about other causes of CNV. This patient of mine with histoplasmosis. It's endemic in the Ohio, Mississippi River valleys, punched out lesions, linear peripheral atrophic tracts, what are those called, Schlegel's lines or something like that. Or maybe that's related to multifocal choroiditis. Don't quote me on that one. Let's just scratch that one. Juxtapapillary chorioretinal scarring with or without CNV in the macula. Absence of vitritis as opposed to MFC, multifocal chorioretinitis. Oh, MCP, sorry, goodness. Multifocal chorioretinitis and panuveitis. So that MCP has vitritis, histo does not. Sorry, I just butchered this for everybody. Just remember, histo, no vitritis. It's bilateral in 60%. Most individuals are asymptomatic until CNV develops. There's my patient. Okay, so what happened to this eye? Answer, blunt trauma. This is a patient that had underlying angioid streaks. This is the fellow eye. You can see the angioid streaks. Folks with angioid streaks, this is a bungee cord injury, by the way. Angioid streaks just make you very susceptible to any kind of trauma. So there may not be any CNV. In fact, there shouldn't be any CNV there. That's just bleeding. Okay, the choriocapillaris got ruptured in multiple places. Usually asymptomatic unless they're subfoveal. Visual disturbance related to that picture. If a patient presents with that picture. It could resolve with no treatment if there's no underlying CNV, and safety glasses always recommended. Here's a differential diagnosis for angioid streaks: Pepsi B, that's an old mnemonic, pseudoxanthoma elasticum, Ehlers-Danlos, Paget's disease, sickle cell disease, idiopathic, always, and beta thalassemia. We'll talk about pseudoxanthoma for just a moment, also called that name that I can't say. Autosomal recessive disorder, mutation of the ABCC6 gene. I've only gotten those genetics back positive once, no, maybe twice. They're at increased risk for peripheral arterial disease and MIs. And in addition to angioid streaks, they may have optic nerve head drusen. They may have this comet sign thing, the mottled RPE appearance known as peau d'orange. And then they also get on their skin this plucked chicken appearance, like around the neck and axial areas. Okay, and that basically rounds out this section. And remember, always wear your eye pro. Thanks very much. Bye-bye.